ecoemulsification lowers the intraocular pressure. We also know that harder and bigger the cataract, more is the IOP lowering effect. Is it only due to deepening of the anterior chamber and widening of AC angle? Then why not this happens in cases of sutured ECC or SICS? So Dr. Donald thought it was probably due to ultrasound energy. Spray of the stray ultrasonic energy is actually cleaning the trabecular meshwork by ab-interno approach because of the sonomechanical vibrations. While giving 30-watt energy at phaco tip, we are unknowingly also giving 3-watt energy to opposite one quadrant of trabecular meshwork. Ultrasound is also known to trigger a cytokine cascade which ultimately leads to a significant reduction in intraocular pressure. Cytokine cascade effect induced by ultrasound is exactly same as that induced by slit lamp laser trabeculoplasty. So we thought that if ab-interno ultrasound in OT can lower intraocular pressure, can we achieve it by non-invasive ab-externo approach in OPD or as an office procedure? So we designed a handpiece and a console to deliver low intensity focused ultrasound of 3-watt power of 40 kHz frequency to the trabecular meshwork as well as to the canal of Schlemm by an ab-externo non-invasive approach. This is how the current working prototype looks like, which weighs less than 2 kilos. There is a console, there is a foot switch, and there is a handpiece. After confirming the safety of repeated procedure in rabbit model in vivo animal studies, we started humanized in vivo studies. TRABOCLEAN is as good as cleaning a blocked tea strainer by sonomechanical vibrations as well as by induction of cytokine cascade, which is analogous to SLT. In fact, SLT only has cytokine pathway, whereas TRABOCLEAN has sonic vibration pathway as well. In this video, we can see the mild but focused ultrasonic vibrations of the probe tip, which are so gentle and so benign that we can actually stop them by forcefully grasping the tip, which cannot be done with a phaco tip, which has a 10 to 12 times higher ultrasonic power. The TRABOCLEAN TUG treatment is non-invasive OPD or office procedure which can be easily performed under topical anesthesia. After insertion of the speculum, the eye is marked at 4 cardinal points around the limbus. 2% lignocaine gel will work as anesthetic as well as ultrasound contact gel for better transmission of the sonic energy. Limbal spot treatments are to be given for 60 seconds at each clock hour position. We can give 4 spots, 8 spots, 12 spots, or 24 spots. 1 spot of treatment approx gives us 3 mm IOP reduction. 5 to 15 minutes is the total duration of TUG treatment, and this medication-free IOP reduction and control will last for approx 6 to 8 months. This is the comparison of number of spots versus pharmacological equivalence of their IOP lowering effect. These are electron micrographs of treated versus untreated areas of trabecular meshwork. In last 13 years, over 900 patients are treated with over 12,000 post-treatment examinations. 50% fall of IOP is measurable in 6 hours after the TUG treatment. In 24 hours, IOP is fully down as per the number of spots. Trabecular meshwork cleansing effect lasts for 6 to 8 months in more than 94% of cases. We give repeat TUG treatment every 6 to 8 months, and it can be repeated as many times as needed for the lifetime of the patient. When we treat the second eye, the first treated eye shows approx 25% further reduction of IOP. So treating 2 eyes separately at an interval of 7 days is more beneficial. This is due to cytokines going to other eye through blood circulation. The dictum is treat the worst eye first. For naive PONG patients, we treat directly. For patients on topical drugs, if we know their virgin IOP max, We treat TUG by n number of spots and stop all medications from that day onwards. For those patients who are on medications in whom we don't know what is their max IOP, then we stop all medications, allow a washout period, measure IOP max, and then treat with TUG for n number of spots accordingly. Best and longer lasting TUG results are found in pseudophakic patients. Very mild discomfort without any pain just for one day is the only post-op symptom. Mild redness and very mild aqueous flare just for one day are only post-op signs. Topical or systemic NSAID or steroids are not to be given because we do not want to suppress the cytokine cascade. They are not even needed. Compared to SLT, TRABOCLEAN gives 20% more IOP reduction. This is the publication about TRABOCLEAN TUG. Ultrasound stimulation on uveal tissue is known to induce long-term secretion of mTOR. mTOR is an enzyme fully named as mammalian target of rapamycin. mTOR is known to induce the regeneration of optic nerve and spinal cord. Activated mTOR induces and enhances retinal ganglion cell regeneration and rejuvenation. We can drive neural regeneration through mTOR cascade. TRABOCLEAN TUG activates mTOR pathway, which leads to retinal ganglion cell regeneration, which not only holds the progression but actually reverses the glaucoma and the field changes. After 2 TUG treatments in 1 year, the RNFL thickness is increased from 0.099 to 0.202. This is another case in which in 13 months after 2 TUG treatment, the RNFL thickness has increased from 0.021 to 0.160. As the RNFL thickness increases, cuffs get filled, so the CD ratio decreases from 0.79 to 0.57 in this case. Press next, RC. In visual fields also, we can document and see these changes. In this case, mean deviation has improved from minus 1.83 to minus 0.91 in 17 months after 3 TUG treatment. In the left eye of the same patient, mean deviation has improved from minus 3.96 to plus 0.04 in 17 months after 3 TUG treatment. TRABOCLEAN is the revolutionary and the only treatment which can reverse the glaucomatous damage. TRABOCLEAN TUG is a double-armed sonic sister of the single-armed slit-lamp laser trabeculoplasty, which is easier, portable, there is no learning curve, and is a lot cheaper than the SLT. Thank you very much for your patient listening.
Thank you so much. Such a wonderful device you have invented. And since how long it's been in practical use now?
In both of our clinics, I think about 4.5 years.
4.5 years.
4.5 years.
Okay, that's very good.
And the thought about increasing the field was given by one of the patients only. He had a very small field before the treatment, and when I did it for the first time, he said that I can see the things from side better.
Okay.
That was the first time we actually thinking and started documenting and he had a significant improvement in the field of vision, plus that has been maintained for last 1.5 years. Okay. And he's my neighbor only.
That's good. So how many sittings he needed to do that?
Anji?
How many sittings were done for him?
We have done 2 sittings so far because he's only 1 year and 2 months, 3 months.
Okay.
7 to 15 days we wait for the other eye. That glaucoma drop is continued till we do, because we don't want anybody to lose the sight. Even
Definitely
if our treatment are not effective.
Treatment for the other eye, that is obvious. Yeah.
But the most important, biggest advantage is redness, the excoriation of skin, everything disappears very significantly. I had one patient which has come from Valkeshwar, which is supposed to be the distant times. It is almost 45 kilometers. She's one-eyed patient. Somebody has told her and she came to us and she was so bad that she was not able to move out of the house because of the drops. 3 drops she was putting it and she was one-eyed. So we did the TUG and we said that you have to follow up regularly. She is off medication for last 2 years with 2 or 3 sittings of TUG has been done. She slightly improved the quality, the field of vision, but she is symptom free and she is so happy. For the first time she said after so many years I am going wherever I want to go, independently. Yeah. 7 days you can wait or 15 days because we want to know whether the effect of this or what procedure has been effective or not. It's nothing, there is nothing standard protocol for that, but we want to be sure that the first eye effect is then we proceed to the other eye. Why we don't do together? Because we have a small advantage of doing the other eye after some time. So there is some amount of reduction in the opposite side also which is treated before.
So when what we noticed was that when we treat the second eye, we get 15 to 20% additional hypotony on the first treated eye. So instead of treating both eyes together, we then started treating at a 5 or 7 days or 10 days interval. That is because of the cytokine advantage, which is induced additionally by the second treatment in the second eye.
See, today the mission for both of us is we don't want a single patient to lose from glaucoma, either the field of vision or the quality of the quantity of the vision. That is the new missions which both of us have taken. So we have 3-4 things which is there with the glaucoma. One of them was TRABOCLEAN, other is that OmniFlow. And
OmniFlow is going to be presented next by Dr. Ankush Mahajan.
And something probably might come in about 6 months' time. So we don't want first the drug-free, the local drops-free, and the second one is that nobody should lose the vision. And probably we might get, if everything goes well, something might happen in USA and we might get the approval from USA.
Right. What is the frequency, the maximum frequency you use in this machine?
Is 40 only.
40,000. Okay. So that is fixed or you can change it?
No, the intensity can be, I don't think we can change the frequency.
Okay.
Intensity.
So the reason for 40 kilohertz selection is that it is the phacoemulsification frequency and it is time tested and safe for the eye and for the uveal tissue. That's why we selected the same. And the effect of hypotony induced by this kilohertz is already well reported, well documented in the previous literature. That's why we selected.
So any side effect like when you are using 40,000 frequency, could there be a heat generation in the trabecular meshwork? Or
No. The wattage is so small, it's a very, very small watt. You can hold actually. You cannot hold the phaco needle in hand. Your flesh will burn with phaco needle holding. But this probe, we can stop from vibrating just by holding it in hand. It's very benign. It's very benign.
And it is designed in such a way that it increases the temperature up to 41 degrees, not more than that. So patient hardly feels that.
Right. So I think this very, very important device
Thank you so much.
Like this should have been presented in the mainstream sessions, and because bringing it to the last session not justified. And what I feel is like we in Delhi Ophthalmological Society, we have 2 sessions on the near innovations, which is going to be in the mainstream. And I'm preparing these 2 sessions. So I would like to have this talk also in that session. So you can send me the topic. I'll put in that innovation session, which is going to be seen by almost 2,000 people. So I think that should be, because at least, because see, these are the, what I feel is like there are so many innovations coming from the West, but we Indians are all doing very, very great work. And at a very minimal cost, that is more important, because we need something like which is reasonable, which is accessible, and works well. So I think these devices, what you have done, especially the camera and this particular machine, I think this should be publicized in a greater way, and people should know like what exactly these means to them. So I think definitely I'll invite you to send me the topics. I'll put in the innovation session. All right.
Thank you.